Welcome, everyone. Today we're comparing video and direct laryngoscopy for tracheal intubation, focusing on recent evidence and its relevance to our practice. We'll explore the techniques, their differences, and what the latest research says about their use in critically ill patients. Introduction to laryngoscopy. Laryngoscopy is a key skill in critical care and emergency medicine. It's primarily used to place an endotracheal tube into the trachea to protect the airway and ensure ventilation. It's not just for intubation, it can also be diagnostic. But our focus today is on its role in securing airways. This is a high-stakes procedure where precision and speed are vital, as failure can lead to severe outcomes like hypoxemia or aspiration. We'll look at two main techniques, direct and video laryngoscopy. Direct laryngoscopy. Direct laryngoscopy is the traditional method for tracheal intubation and has been the standard for decades. The technique involves using a laryngoscope, which is a handheld instrument consisting of a handle and a blade, typically a curved Macintosh blade or a straight Miller blade. The goal is to directly visualize the vocal cords by aligning the oral, pharyngeal, and laryngeal axes. Here's how it works. Patient positioning. Before starting, the patient's head and neck are positioned to facilitate visualization. This is often done by placing the patient in the sniffing position, where the neck is slightly flexed and the head extended. This alignment helps straighten the airway passages, making it easier to see the larynx. Blade insertion, visualization, and tube insertion. The operator stands at the head of the patient and inserts the laryngoscope blade into the patient's mouth. For a Macintosh blade, the tip is placed in the vallecula, the space between the base of the tongue and the epiglottis, while for a Miller blade, the tip is placed under the epiglottis to lift it directly. Once the blade is in position, the operator lifts the handle forward and upward, without levering on the teeth to displace the tongue and epiglottis. This action exposes the glottis, allowing the operator to see the vocal cords directly through the mouth. Achieving this direct line of sight is critical. If the axes aren't aligned properly, the view may be obstructed, making intubation difficult. With the vocal cords in view, the operator passes the endotracheal tube through the mouth, between the vocal cords, and into the trachea under direct visualization. The tube is then secured, and placement is confirmed with capnography or auscultation. Advantages and limitations of direct laryngoscopy. There are several advantages for using direct laryngoscopy. First is familiarity. Most clinicians are trained in direct laryngoscopy, and it's the go-to method in many settings. Next, availability. It requires only a basic laryngoscope and blade, which are widely available in hospitals and ambulances. And lastly, no additional equipment needed. Unlike video laryngoscopy, there's no need for screens or cameras, making it simpler in resource-limited settings. There are also several limitations for its use. First, a direct line of sight is required. The need to align the airway axes can be challenging, especially in patients with anatomical variations like a small mouth, large tongue, or limited neck mobility. Next is with difficult airways. In cases where alignment is poor, for example, anterior larynx, cervical spine immobilization, obtaining a clear view can be difficult, increasing the risk of failed attempts. Lastly, direct laryngoscopy is operator-dependent. Success relies heavily on the operator's skill and experience, particularly in positioning and manipulating the laryngoscope. In summary, direct laryngoscopy is a tried-and-true method, but can be technically demanding, especially in patients with difficult airways. This is where video laryngoscopy offers an alternative approach. Video laryngoscopy. Video laryngoscopy is a more recent innovation that enhances visualization by using a camera mounted on the laryngoscope blade. The camera transmits a real-time video feed to a screen, allowing the operator to see the airway indirectly. This method eliminates the need for a direct line of sight, which can be a game-changer in difficult intubation scenarios. Let's look at this in more detail. Blade types. Video laryngoscopes come with two main blade geometries, standard and hyperangulated. Standard geometry blades resemble traditional Macintosh blades and are used similarly, but with the added benefit of video. Hyperangulated blades have a more pronounced curve, designed specifically for difficult airways where alignment is challenging. They provide a better view around anatomical obstacles. Patient positioning and blade insertion. While the sniffing position is still helpful, it's less critical than in direct laryngoscopy because the camera provides a view regardless of axis alignment. This makes video laryngoscopy particularly useful in patients with limited neck mobility or cervical spine precautions. The operator inserts the video laryngoscope blade into the patient's mouth, positioning it near the epiglottis. For standard geometry blades, the technique is similar to direct laryngoscopy. For hyperangulated blades, the blade is inserted midline, and the camera is used to navigate around the tongue and other structures. Visualization and tube insertion. Instead of looking directly into the mouth, the operator watches the screen, which displays a clear, magnified view of the larynx. This indirect visualization allows for better identification of the vocal cords, even in cases where direct laryngoscopy would be difficult. With the vocal cords visible on the screen, the operator guides the endotracheal tube, often preloaded with a stylet or bougie for hyperangulated blades, into the trachea. Because the view is indirect, the operator must coordinate hand movements with the screen image, which can take some practice. Advantages and limitations with use of video laryngoscopy. Advantages. Improved visualization. The camera provides a wider, clearer view of the airway, making it easier to identify the vocal cords, especially in patients with difficult anatomy. Higher success in difficult airways. Studies, including the device trial, show higher first-attempt success rates in challenging cases. Teaching and collaboration. The screen allows others to see the airway in real time, making it an excellent tool for teaching and for getting assistance during the procedure. Limitations. Equipment and training are required. Video laryngoscopes are more expensive and not always available, especially in smaller or resource-limited settings. Operators also need specific training to use them effectively. Depth perception. Since the view is on a screen, some operators may struggle with depth perception, particularly when inserting the tube. This can be mitigated with practice. Reliance on technology. If the screen malfunctions or the camera lens becomes obscured, for example, by secretions, the operator may need to switch to direct laryngoscopy or another method. In summary, video laryngoscopy offers significant advantages in terms of visualization and success rates, particularly for difficult airways. However, it requires specialized equipment and training, and operators must be comfortable with the indirect nature of the technique. Comparison of techniques. Let's compare these head-to-head. Success rates for first-attempt intubation are generally higher with video laryngoscopy. Studies show it shines in difficult airways. Complications like severe hypoxemia or hypotension are similar between the two, but multiple attempts with direct laryngoscopy can up the risk, as each try stresses the patient more. Ease of use is interesting. Video laryngoscopy might be more intuitive since you're watching a screen, potentially shortening the learning curve. That said, both require training. The device trial, which we'll cover next, showed video's edge when operators are skilled with it, suggesting experience is a big factor. Evidence from recent studies. The device trial, published in 2023, is our key evidence. It's a large, multi-center, randomized, controlled trial with 1,417 critically ill adults in EDs and ICUs. They found video laryngoscopy had an 85.1% first-attempt success rate compared to 70.8% for direct, a 14.3% difference that's clinically significant. Severe complications like hypoxemia or cardiac arrest were about 21% in both groups, showing no safety trade-off. The trial stopped early because video's efficacy was so clear. A critical point, 91.5% of intubations were by residents or fellows, most with solid video laryngoscopy experience, median 50 prior intubations, often favoring video. This suggests training is key to these results. The editorial we reviewed supports this, arguing video laryngoscopy could be standard with proper training and tools like bougies. Practical considerations. So, When do we use each? Video laryngoscopy is ideal for difficult airways. Think obesity or limited neck mobility, or when that first attempt is critical, like in unstable patients. It's also forgiving for less experienced operators. Direct laryngoscopy still has its place. If video gear isn't around or you're a pro with direct, it's reliable. Practically, many sites are shifting to video as standard, but we must stay sharp with direct for emergencies. Simulation training is gold. Practice both to handle any scenario. Conclusion and future directions. To wrap up, video laryngoscopy boosts first attempt success, 85.1% versus 70.8% in the device trial, without increasing complications, making it a game changer for critically ill patients. But it's not a magic bullet. Training and experience drive its success. Mastering both keeps us versatile. Looking ahead, we need more on long-term outcomes and cost. Video gear isn't cheap. Optimal training methods are also key as video use grows. Stay curious and keep practicing. Technology's evolving, and so should we. References. These are the key references for today's presentation. The device trial is a pivotal study that directly compares video and direct laryngoscopy in critically ill adults, providing robust evidence for the higher first attempt success rate with video laryngoscopy. The editorial by Freund and Bloom offers insightful commentary on the trial's implications and the importance of training in achieving these outcomes. I encourage you to review these articles for a deeper understanding of the topic. Thanks for listening.